Well, welcome to today's DFMCH forum on COVID-19 disease and vaccine updates. My name is Dr. Melissa Stiles. I'm the Director of Faculty Development. And just as a gentle reminder, when you're joined, to please mute. We'll have questions at the end, but feel free to put them in the chat along the way, and I'll try to curate and bundle them up and ask questions then at the end. There is CME credit. There was an email that was sent earlier with the QR code. If you do need that, you can just email Sue McGuire and she can send you the information, and her information is in the chat. So very pleased to present Drs. Paul Hunter and John Temte. We have such expertise in our department related to COVID and the vaccine. Dr. Paul Hunter has worked with the department or with the Milwaukee Health Department as Associate Medical Director. He's a voting member for ACIP and is right in the thick of the vaccine approvals. So he'll be giving more of the national perspective. And Dr. John Temte, who is Associate Dean for Public Health and Community Engagement for School of Medicine and Public Health, is professor in the department and does research on viruses, influenza. He is also part of the Wisconsin committee in terms of the rollout of the vaccine. So we're getting a perspective of what's happening in Wisconsin. So thank you so much both for joining us, and we'll let John lead it off.
Well, thank you so much, Melissa, and it's a great pleasure to be presenting today with my good friend Paul and talking about something that we are both passionate about, vaccines, and unfortunately how they apply to COVID-19. Paul and I decided to kind of split things up a little bit here. We're going to talk on both science and policy, and I'm going to lead off talking about some updates on COVID-19, particularly with epidemiology and different strains and their ramifications, make a quick mention of herd immunity, and then I'll turn that over to Paul to give the science behind some of the vaccines out there that we are getting more and more familiar with. Then we're going to pivot and talk about policy. Paul will continue talking about the Advisory Committee on Immunization Practices and their role in vaccine policy. And then after that, I will talk a little bit about the Wisconsin adaptation of ACIP and CDC guidance for allocation, and finish up with just a little comment on vaccine hesitancy. So, as we all are aware, we are in the midst of an unrelenting global pandemic. As of this morning, we're edging up toward 100 million cases, 2 million deaths. For the US, we're now at 385,000 deaths. And Wisconsin, we're getting pretty close to 10% of our population with a known infection. And we're getting pretty close to that mark of 1 out of 1,000 Wisconsinites dying of this virus. Of interest of late has been the coronavirus mutations and the capacity therein. And as an RNA virus, coronavirus has a higher rate of mutation. The good news is it's less than our friend influenza, and that's because coronaviruses encode an enzyme that corrects some of the errors that occur during transcription. It's worthwhile to talk a little bit about some of the new variants out there and the fact that new variants can come into abundance due to chance. For example, it's the only virus around that hits a population, or can come from natural selection, and particularly with higher transmissibility. But keep in mind that oftentimes most mutations are selected away from due to purifying selection and getting away from things that reduce the fitness of a virus. Oftentimes in the literature and on media and other places, you hear mutation versus variant versus strain. A mutation is simply a base pair substitution in the genome that we can pick up doing whole genome sequences. A variant can be a virus that has one or more mutations compared to another virus. But a strain is when we start seeing those variants that have some phylogenetic differences. So for example, if we look at transmissibility or things like pathogenicity, we reserve the term strain for those. So this is what we're looking at for US cases with that first eruption in March and April. We had kind of a peak in July following 4th of July, dropped down a little bit, but never back to where it was. And now we're in kind of our third big spike up, unfortunately. We saw this coming as early as last April, and unfortunately, those predictions turned out to be quite accurate. Likewise, with death, we saw an awful lot in that very first wave. We learned a lot about this virus and how to deal with it in the hospital setting. We saw less of a death rate during the summertime, but unfortunately now we are hitting record numbers of deaths per day in the United States. So unfortunately, by the end of January, we're going to be well over 400,000 deaths due to this virus. So some of the epidemiological considerations very quickly, two very recent papers, one looking at comparisons to influenza from France. And the thing to keep in mind is COVID-19 much more likely to result in acute respiratory failure, pulmonary embolism, septic shock, and hemorrhagic stroke. And interestingly enough, for adults, it's almost a threefold increase for in-hospital mortality for people with COVID-19. For adolescents, it's a tenfold increase in mortality. And for ICU admission, about 2.3-fold higher for young children under 5 years old. Recently, we've heard about asymptomatic transmission, and the bottom line is about 60% of cases are transmitted before people have symptoms, and some of those people will never have symptoms. So basically about 30% of individuals are never symptomatic. And from this modeling study, it looks like most of our transmissions are occurring at a time when people aren't aware of it. And that's why that's why having that mask is very, very important, because that really reduces that potential for transmission from those people who don't think they have it. This kind of goes in our Swiss cheese model of personal responsibility and shared responsibilities, that no one intervention is going to be curative for this pandemic. We have to use everything together. When we look at the emergence of strains, this is data recently presented for the UK. And I just want to point out here that a number of different strains have been noted in the UK, but you've heard of the B117 strain, and that's this one here. When it was first detected, it was detected with about 26 mutations compared to where things were before that. And the concern we have for B117 is, even though it emerged not that long ago, it now comprises nearly 30% of the cases in the UK. It's just exploded, as you can see at the tail end. For those of you who are really into the epidemiology and molecular evolution, go sometime to nextstrain.org. And it brings out kind of the global picture of viral evolution. And again, here is that B117 that is just recently appearing and starting to dominate everywhere. And by the way, yesterday in Eau Claire, the first case of B117 was noted in Wisconsin. So it is here. Just going to finish up here with talking about the herd effect. And we've heard about how important it is to get immunity up there. And this is something I prepared some time ago, looking for a herd effect threshold of about 60%. And if we assume that maybe 10% of us have the virus and recovered, it leaves room for another 50% to be vaccine induced. immunity. And to get there, we have to kind of look at the effectiveness of a vaccine and multiply by the vaccine coverage to get to that, let's say, 50% needed. And that's why vaccine hesitancy, as I'll talk about later, is really, really important. Now, this is a paper that was from JAMA describing herd immunity. And across the bottom, you find the basic reproductive number. That's the number of secondary cases in a totally susceptible population generated by each case. And at the top end is our friend measles. And in the black, you find the basic reproductive number for SARS-CoV-2 and the herd immunity threshold at about 60%. But what happens if you have a new strain that has greater transmissibility? The B117 strain is about 1.7 times more transmissible, and this is what happens. It forces us now to start thinking in terms of not getting 60% of the population immune, but 75%. And that is going to be an astronomical leap that we have to take. That basically is 50 million additional Americans that will need to be vaccinated. So with that happy news, I'm going to turn things over to Paul and have him give us an update on the current vaccines.
Sure, thanks, John. There's three types of vaccines in trials in the United States: mRNA, viral vector, and subunit. The mRNA vaccines you're familiar with because they're being given out now, the one from Pfizer and BioNTech, and the one from Moderna. I'll talk about these individual vaccines on the upcoming slides. mRNA vaccines obviously instruct the vaccinated person's cells to make the COVID spike protein, and they work outside of the nucleus. They're not rewriting your genetic code, and mRNA breaks down quickly. Viral vector vaccines, like the ones some of you may have gotten or gotten the placebo of for the AstraZeneca trial, and the one from Janssen or Johnson & Johnson, they use a weakened version of adenovirus, not the COVID virus. And they basically, there's DNA genetic material from the COVID virus inserted into the adenovirus. John, there, I think you may have opened some screens that are, there you go. I need to, if you back up one, John. There you go. So the viral vector, it also instructs the vaccinated person's cell to make the COVID spike protein. Novavax makes a protein subunit vaccine that's composed of just the proteins itself. There's no mRNA or DNA in it, and that's also works outside. That works outside the person's cell mostly. If you could now move on to the next slide, John. So the first mRNA vaccine that came out was the Pfizer BioNTech vaccine. In the phase 3 trials, it has a 95% efficacy. It was got emergency use authorization in ACIP recommendation in the middle of December. It's 2 doses. Many of you are getting this one, and you know it's 3 weeks apart. I'll be getting mine tomorrow, my second dose. Stored at minus 70 degrees centigrade, and that's much lower than you can get in your average freezer. Once you thaw it, you can only have it out for 5 days. There are rare anaphylactic reactions, and that might be due to the polyethylene glycol. There's lipid nanoparticle, or a little ball of lipids that the RNA is inside of, and one of the 3 lipids that's used in there is pegylated. It has polyethylene glycol as a moiety attached to it. There's a contract for 200 million doses of Pfizer vaccine in the United States through 2021. Next slide. The second mRNA vaccine is from Moderna. It's a small company that hasn't had as much experience making and distributing a large amount of vaccine before. So hopefully they'll have as much infrastructure as Pfizer has so far. The advantage with this one is that it doesn't have to be stored at a unusually low freezer temperature. This is your average freezer temperature that, say, varicella vaccine is stored at, and that once it's thawed, it can be kept at refrigerator temperatures for 30 days. It also has efficacy of 95% in the phase 3 trials and came out 1 week later than Pfizer. It's 2 doses, 4 weeks apart instead of 3 weeks apart. Again, rare anaphylactic reactions, maybe from the PEG. And there's currently a contract for 100 million doses in the United States, but there's option for 400 million more doses if needed. AstraZeneca is the one of the viral vector vaccines. It's using an adenovirus that usually infects chimpanzees. This one is in the 11,000 person phase 3 trial that had interim results in December. When they did it according to protocol with 2 standard doses, the efficacy was 62%, but there was a happy mistake they made that accidentally gave a low dose for the first dose and then followed by a standard dose, and that unexpectedly had a higher efficacy. So there's still some follow-up on this that needs to be done. We'll see what the actual efficacy is. This is 2 intramuscular doses 4 weeks apart. Good thing about this is it's refrigerator stable for 6 months. So, and also can be mass produced in large amounts at a relatively inexpensive cost. And we have 300 million doses on order for the United States. Next slide. Another viral vector vaccine. This one is the only one that has a 1-dose regimen. They're also studying a 2-dose regimen, but their main study so far has been a 1-dose. It uses adenovirus 26, a human adenovirus that's also been used as a backbone for the Ebola vaccine and some other diseases, other vaccines. It should have results sometime in January from a large phase 3 trial, so we'll see what the efficacy is then. It can be stored frozen for a long time at the usual freezer temperatures, and then for a nice long time of 3 months at refrigerated temperatures. We got 100 million doses on order in the United States. Novavax is the last one. It's another small company that has other entities that they use that basically sticks proteins onto nanoparticles or microscopic particles. And that's the idea with this, is to stick, I assume it's the spike protein onto the small particles that would then present the antigen to the immune system. Don't know how efficacious it is so far. They just started a phase 3 trial in the United States with a large number of folks at the end of December. So we'll see when we get the results from that. But the early trials are hopeful. It's another 2 IM doses. This one's 3 weeks apart. This one's also stable in the refrigerator, and we got 100 million doses on order for the United States. Switching gears, the ACIP is the Advisory Committee on Immunization Practices that provides advice and guidance to the Centers for Disease Control and the Health and Human Services Secretary. And on what we provide advice on is the most effective means for preventing disease in non-military populations, although the military usually follows closely behind what ACIP does, or sometimes in advance of. And it's not just vaccines necessarily, it's also other stuff. It can include unlicensed vaccines or ones that have emergency use authorization, like the COVID vaccines. Next slide. There's 15 voting members. I just ended my term at the end of December, and I'm sort of glad because they're going to have some really difficult decisions making coming up. It's a really good group of people, very diverse, professionally, personally. We had a 4-year overlapping term, so 3 or 4 people come on and off each year, and lots of other administrative stuff that I'm not going to go into right now. Next. So the principles of who gets the vaccine first that the ACIP used was a 3-legged stool. One is based on the science about the disease burden or epidemiology, and then the effectiveness and side effects of the vaccines themselves, which comes from the phase 3 trials. Then there's the implementation issues that I'm most familiar with. The values of the target groups, whether or not people are going to take the vaccine, and then the logistics of how feasible it is to get the vaccine out. So that's how many doses, how far apart, freezer temperatures, that kind of stuff. And then what's really been overriding, because the science and implementation aren't that much different between the different vaccines and the different priority groups, is the ethical principles. Maximizing benefits and minimizing harms for particular groups, which, again, that's not a lot of differences between the groups that we know of from the phase 3 data. But promoting justice, mitigating health inequities, and promoting transparency, big differences between the various groups, which I'm happy to take some questions about, and John will probably talk about, and how it's being implemented through SDMAC at the state level. Next slide. Towards the end of December, the ACIP voted on the 1B and 1C, phase 1B and 1C priority groups. We voted a week before on the phase 1A groups. But I'm focusing on the phase 1B and 1C groups because phase 1A is pretty straightforward. It's healthcare folks and people in nursing homes and assisted living. But phase 1B and C groups are a little more complicated, and there were some changes between the original proposal and what we actually voted on. If you look at it, balancing health and societal needs, if you're looking at preventing mortality and morbidity, then phase 1A is really about focusing on the residents of long-term care facilities, because they make up a small percentage of the population, but they make up a large percentage of the hospitalizations and deaths. Plus, you're going to be going in anyway from a feasibility point of view and vaccinating the staff of the nursing homes. So why not just catch the other people in that congregate living situation anyway? Then phase 1B, the new thing that happened in the ACIP was bringing in the 75-year-olds and older from phase 1C into phase 1B. That was the change that was made between November and December. So that's further being clarified, as John will probably talk about, in the Wisconsin, based on Wisconsin epidemiology and ages. And then phase 1C is 65 years and older, and then the 16 through 64-year-olds with medical conditions. And you'll see that basically phase 2 is everybody else, which basically is 16 to 64-year-olds that don't have medical conditions and aren't in any other group. If you're looking at trying to preserve societal function and keeping the health system running, taking care of people that had COVID, that's why people in phase 1A are healthcare personnel. If you're looking at keeping other stuff going and support to healthcare personnel, you're looking at frontline essential workers, people that have to be within 6 feet of other people at work, or are within 6 feet of people that they work with and serve. And then there's other essential folks that can work from home. I got another slide on these two groups coming up very soon here. Next slide. If you look at these phases a little bit differently, the lightest phase is phase 1A. It is the HCP, the healthcare personnel in the small oval in the middle, and then the long-term care facility folks on the small oval down in the older age groups. So that's phase 1A. And proportionally, that's about the percentage or the proportion of the total population of the United States they make up. Phase 1B is a little bit darker blue there, and that's the frontline essential workers, and then the 75-year-olds. And then phase 1C is the large group of the dark blue there, and you can see how that is a proportion of the U.S. population. You'll see the phase 1C, the healthy folks that are 16 to 64-year-olds that aren't in any essential worker category. It's actually a minority of the population. So by the time we get to phase 2, we're going to be sort of mopping up as from a population point of view. Next slide. This is another way to look at the fine points between the essential workers of what frontline essential workers are. You can see the list of them. I think the little red box towards the bottom is the important thing that I said before, that their work-related duties must be performed on site or within 6 feet of their coworkers. And then the phase 1C folks are the essential workers, and there's examples of them there. I'm not going to go into the details right now. Next slide. And that's a federal level, that's not the state level. This is a way of looking at the timeline that the phases can overlap. For example, in Wisconsin, the police and fire are going to be, next week are going to be starting up as the phase 1A folks, police and fire in phase 1B, and the phase 1A folks and healthcare personnel are finishing up. So that's an example of how these are overlapping. And approximately the number of weeks in the different groups, maybe according to supply and demand. So we're looking, 5 months out? That's probably very optimistic. 5 months, 6 months to get everybody vaccinated. That's probably very optimistic. Next slide. Next slide. This is an important thing that is not just on a state level, but probably on a healthcare organizational level of, when do you decide to finish up your phase 1A and move on to 1B and move from 1B to 1C. As I said before, the phases may overlap, and you need to make this decision on a local level. So, different places are going to have different transitions, and that is going to require some, high level messaging to make sure everybody understands that, yep, that's just what's going to happen. Different places are going to be different times. It's not, and that's just because of how things are set up. The potential criteria to look at is your supply more than your demand? And the ways of looking at that are less than 80% of your appointments filled for several days in a row. And that's probably the easiest operational thing to look at say UW Health level. Another way to look at it from a more local health department way are more than 60 to 70% of the people in a particular phase already vaccinated. Then you can look at starting to get started on the next phase. I think that might be my last slide. Yeah. Thanks, John.
Okay. Well, thank you so much, Paul. I'm going to now pivot to looking at Wisconsin adaptation of everything that Paul just mentioned. And the first thing I want to toss out is that anyone who is providing vaccine, and this is a healthcare entity or a vaccinating entity, has to sign a provider agreement. And so I've done this for Public Health Madison and Dane County. I'm not sure if Paul has done this for City of Milwaukee or not, but one of the stipulations is that organizations must administer COVID-19 vaccine in accordance with all requirements and recommendations of CDC and CDC's Advisory Committee on Immunization Practice. So I want that out there as a starting point. There are some regulations out there that we have to adhere to the federal guidance. For the State Disaster Medical Advisory Committee, we have a vaccine subcommittee that I co-chair with Ann Lewandowski. And our job is to provide policy options to the SDMAC, so the larger committee. We review the science, ethics, and feasibility issues. We adapt CDC guidance to Wisconsin. We deliberate in open forum. There has to be an approval by the majority of voting members to advance this to public comment. There has to be a public comment period. This is all part of state statutes and function. Then we have to review and revise based on public comment, and then we vote to move to SDMAC. So if you're following this, all of a sudden you're seeing that this is not an efficient process. Paul and I could do a much better job, over a phone call in 30 minutes, but this is something that takes a long time to do. And it generates all sorts of angst amongst the public, amongst our legislators and others. But this is the process that is required for making public policy in a transparent and open manner. We then vote to advance this to the full SDMAC, and then they review and revise it as appropriate, and when ready, they vote to approve the policy. When the policy is approved, it goes to the Secretary Designee of the Wisconsin DHS. And I'll just remind everybody that even though we are a year into a pandemic, we still do not have a confirmed Secretary of DHS. And once it gets to the secretary, they can take the policy or they can chuck it. And that's exactly the same that Paul knows with ACIP, that we're purely advisory. We're giving the best information and we then pass it off. So as of today, we have met a total of 20 times, which means the steering committee has met about 40 times. And this has been a considerable number of shared hours. This is kind of where we are. We're in phase 1 right now in progress. This is a graphic from Rural Wisconsin Hospital Cooperative that can be used to inform your populations, who gets it, what to expect, how to keep others safe, and learning more. So phase 1A was approved in Wisconsin on the 17th of December and deals with healthcare personnel and long-term care facility staff and residents. So about 540,000 people, or roughly 10% of our state. Phase 1B has been advanced to public comment as of 2 days ago. And I won't go through the numbers, but this now represents about 1.2 million additional people. So if you add these two together, we're now up to about 40% of Wisconsin, which is a big number when you consider the allocations and the ability to vaccinate. But keep in mind that in Wisconsin, we push the age down a little bit based on local characteristics and morbidity and mortality. We have the IRIS and family care recipients. These are people who qualify for long-term care but live in the community. We faculty, staff, and residents of congregate living settings, including incarcerated individuals. And what I can tell you is the most flack we're getting from the public is, why do criminals get to get the vaccine before I do? But if you go back to what Paul was saying about having an ethical framework, looking at health equity issues, looking at access to care and so on, that really clearly fits into that. Then we have the public-facing essential workers, so non-EMS first responders, education and childcare to get society back functioning again, non-frontline healthcare personnel, and Wisconsin is unique. We have mink husbandry. And the reason why this, for these 300 people, is because people can transmit COVID to mink. Mink, it can be explosive in a husbandry setting, and they can transmit it back to humans with a whole bunch of new mutations. And Denmark is the ground zero for that phenomenon. They ended up culling 17 million mink because of this problem and the transmission of new virus strains back to humans.
My parents were part of that population at the beginning of their marriage.
So here, it just kind of shows what we're looking at in Wisconsin in terms of our planning, in terms of percent of population compared to ACIP. And we're fairly close, but we chose to make 1B a little bit smaller to try and get vaccine out a little bit better. And the box that says, or the triangle that says vaccine supply, nobody knows. As far as we know here in Wisconsin, as of yesterday, we've had 600,000 doses allocated, 370,000 shipped, and about 30% of our phase 1A recipients have now received vaccine. So the rollout is slow and it is cumbersome, but it's happening. And I remind everybody that a year ago, none of us knew what COVID-19 was. And here we're now 30% of our healthcare employees or personnel are vaccinated. Just another graphic if you're interested in going on the DHS website. And I'm just going to finish up now really quickly with this continuum of vaccine acceptance. We have individuals who refuse everything. We have people, many of us on this call, who accept virtually everything, though I have to confess I have not received my Shingrix yet. And then you have the people in between, which are the vaccine hesitancy, the people who will refuse but are unsure, people who accept some, delay some, refuse some, and those who accept but aren't sure. And they all fit in. But I think this is really important because this is a great study done by one of Paul's colleagues on ACIP, I believe. This is the only longitudinal set in the nation, which is a nationwide survey that is stratified, that looks at opinion over time. And unfortunately, we have dipped and stayed below 60% since August in terms of acceptability for adults. And all I'm going to say is that if you have a 95% effective vaccine and you have 57% or 58% people receiving that, we're not going to get to herd immunity with a vaccine. The other option is to get to herd immunity by infection, and that worked out very, very poorly for the nation of Sweden. So with that happy note, I will turn things on over to Paul and myself and to our audience for your questions, comments, and otherwise. So thank you so much.
Well, thank you, guys. Thank you both so much. A lot of great questions coming in. We'll start from your first comments, John, in talking about any predictions for a next surge. What should we be preparing for?
Boy, it depends on where, because we're in the midst of a tremendous surge right now in the U.S. And like with many things virologically, things are not evenly distributed over everybody. So Wisconsin right now has the benefit of being kind of at a lull period, but two things to kind of keep in mind. We have not had the severe outbreaks of New York or California at this point in time, which means there's still a lot of susceptible people out there. Number one. Number two, the university system is reactivating next week. Number three, there's a huge push to get K through 12 back into face-to-face in-person instruction. And the wild card is now we know B117 is here. That doesn't surprise anybody, but I think those things together over the next month probably going to mean we're going to be on the upswing again.
Okay. And back to talking about just transmission and when someone is most highly infected. Are most of them when someone is non-symptomatic? And the question also ties into, is screening effective? Why are we still taking temperatures at clinics and hospitals?
That's a good question. I think I'm going to just go back to that Swiss cheese model that is screening alone effective? Not at all. And if we think that about 60%, 59% of transmission occurs with somebody who is asymptomatic, screening makes us feel good, but it doesn't really help a great deal. But it does help a little bit, reminding those people who are symptomatic to stay away. So that in itself is good. So I think we have to look at all these things taken together as an important. Paul.
Yeah, so one thing I would say about the screening for fever is the first symptom or first sign, and it happens before people feel that they're sick. And using the 100.0 rather than 100.4, and the usually I think it's way oversimplification, but one study of a moderate amount of people showed that basically the first symptom you get is fever or sign, and then 1 day later you get a cough, and 1 day later you can get shortness of breath, and that is sort of a stereotypical progression of the most common symptoms. So, the way I've been teaching the case investigators at the City of Milwaukee Health Department, and my weekly update on them is to, get those thermometers we have out, we have available to send out to the contacts, out to them so that they can maybe pick up their their development of COVID one day earlier than we might be able to otherwise. And so, every day could make a difference, especially the early days make a difference as far as transmission. So that's just another way of looking at it.
Great. The next question is about after the immunization. Are you aware of any data about antibody-mediated enhancement that then would lead to contracting more severe disease soon after vaccination before neutralizing antibody titers are achieved?
John, I think you might know a little bit more about that because you're on the work group and probably, yeah.
Yeah, that was a real big question in many people's minds about the vaccines. And for people who aren't aware, there's a concern that priming the immune system with a vaccine, or sometimes with a previous case of the virus, might lead to somebody over-responding next time. And keep in mind that with COVID-19, a big part of the clinical syndrome is not just the viral infection, but it's the immune response to that viral infection that really leads to a lot of those terrible outcomes. So early on, there was a lot of work done with that. And in the phase 1 and 2 trials that Paul was talking about, these things were looked at. And if you look at the balance between Th1 and Th2 response in terms of the inflammation, and these are things well beyond my pay grade, but the balance was very, very favorable against this immune or this antibody enhanced illness. So right now we're not particularly concerned with that, but, and I add this in, whenever you have these large trials being done looking at safety, the standard is to look for about 6 weeks after the last dose to pick up on immune-mediated responses. But characteristically, these studies go on for 2 more years. And the reason they go on for 2 additional years is looking exactly for that. The good news is we haven't seen anything like that as of yet, but this is why it's really important for people to be aware. And if they're seeing anything suspicious, being very active in reporting, talking to public health, talking to other experts out there, and making sure that we're not missing things like that.
So there's an adage, I think, that Paul Offit, some of you might know him from Children's Hospital of Pennsylvania. His mentor was Hilleman, I think his name was, who developed a bunch of vaccines. And Paul Offit, I think I'm probably going to misquote him, said that Hilleman said, I don't sleep at night until my new vaccine has been the 3 millionth dose of my vaccine has been given in the real world. And I said that to somebody just yesterday, and I was like, oh my gosh, we're almost there already. So I think, part of the safety is in just, giving it to a bunch of people and see what happens. And we are seeing that there's more anaphylactic reactions than there are, say, with influenza, but we're not seeing anything obvious early on here and people are getting, between the first doses are getting infected and they're getting exposed. So, we should know soon if there's anything that's really rare coming out.
Great, thanks. This is a more specific question related to leukemia survivors that have had anaphylaxis to a chemotherapeutic agent, PEG asparaginase. The question is, should they not get the mRNA vaccine? Or is there anyone that absolutely should not get it?
So, John, correct me if I'm wrong, but I still think that that's a precaution, not a strict contraindication of what I voted on. I'd have to look at it. I always have to go back and see what I voted on and when we get down to those details. Am I right so far?
I believe so. That I think if someone has had an anaphylactic type reaction to something containing PEG, I think that pretty much comes close to the contraindication. But I'll direct people to the CDC website. They have a very, very nice one it's a couple screenshot, but interim considerations for mRNA vaccines. And there's a whole table at the bottom that gives you the green for people with underlying medical conditions and allergic. The green go ahead, the I believe it's orange precaution, and the red do not vaccinate. And that is really good guidance. The other thing I'll just put a plug out, though, is that as we start moving from providing vaccine in large healthcare centers to our clinics, that this is a good time to review your protocols for anaphylactic disease management, making sure that you have epinephrine on your crash cart, making sure you have diphenhydramine available to give to your patients, and kind of reviewing those protocols, because I think that's important. As Paul mentioned, it's for Pfizer, it's been about 1 out of every 100,000 people with having anaphylaxis. And about 80% of the people who had anaphylaxis had an underlying history of allergic disease. And I think, I'm trying to remember, but about 70% of those, of everybody, had their anaphylaxis within 15 minutes of administration of the vaccine.
30 minutes.
Now, I think 70% within 15, and about 86% within 30 miness. So
that's the group of the first 10 days on the VAERS. Yeah.
Yep. So
yeah, it's a great MMWR article. The other thing I was going to say, just explain what I've been doing in Milwaukee. Well, I have been physically on site when they did it, but just to pass through. But they have a vaccination clinic at the convention center there, and it's 2 blocks from the main fire department. And there's paramedics, 1 or 2 of them on site all the time, and they have equipment to intubate right there. And I just had correspondence with the Sinai ER doctors and the EMS folks, just saying, hey, this is what our plan is. We're thinking they're going to be sent directly to you. So if you're working with a mass clinic site, or if you're working with a vaccination clinic site, you may want to think about those kind of things. It's just, who are you going to call to let them know, and which hospital they're going to go to? How would they get intubated if you needed to? It's, if you think about it, it's not going to happen, but it's, on average, more likely to happen than in a flu vaccination clinic.
And just for everybody's sake, I just put in 4 references into the chat function on vaccine safety and management of anaphylaxis and so on, and that clinical consideration that I mentioned.
Great. I'm going to tie a couple questions together related to both the distribution, where its vaccine will be distributed. Is it going to be primary care, hospital? Are we going to branch out from the hospital doing it only? And then along with that, how are we going to plan for outreach to patients? And they're ready to get it.
Yes, wonderful questions, and I think both of us will take a stab at this. For the state of Wisconsin, we have 1,200 registered vaccine or vaccinating entities out there. And so whether you know this or not, your clinic is probably already registered. Pharmacies are registered and so on. And with the Pfizer vaccine, that really rolled out to large medical centers with hyper cold freezers. The Moderna vaccine will be shipped, I believe, directly to the vaccinating entity, to clinics and to pharmacies, because of the easier storage aspects and the fact that it doesn't come in as big of a box. And so the distribution is really based on where we are in terms of phases, people putting in the request for the number of vaccine doses they need, and the ability of the state to fill those. I'm going to be an apologist for the Wisconsin immunization program, because one of the things that they're hamstrung with right now is the fact that from week to week, they don't have a clue as to how many doses they're going to be receiving from the federal government. There has been a very noted lack of transparency in terms of what's available, what's going to be coming, and it makes it nearly impossible for anybody to plan. Paul, do you have?
Yeah, I guess part of my benefit of being a medical consultant and not having direct responsibility for implementing this kind of stuff is that I can step back and look at things a little bit more abstractly. And the way I'm looking at this is that phase 1A, had two parts to it. One was done through the healthcare facilities themselves, especially hospitals, and taking care of their own folks. And now in the end of phase 1A, the local health departments are helping, and some of the healthcare folks are helping take care of the unaffiliated folks that aren't employed in large healthcare systems. And then on the long-term care facility side, there's pharmacies that are involved with a national program, something I think pharmacy partnership program or something like that, that funds and distributes vaccines directly to them. So that's sort of phase 1A. And then phase 1B, then you start going, okay, how we've got the healthcare organizations that are in the pipeline to getting their vaccines. We got the local health department folks, but then there's, how do we get them from these employers that have these phase 1B people, and how do we hook them together? And so what's happening through the Milwaukee County Unified Emergency Operations Center, UEOC, is a website called Healthy MKE, where literally you can go in and say, I'm a vaccinator that just started up this week. I'm a vaccinator. I'm willing to take on unaffiliated 1A folks. Here's how much I'm willing to take. Well, I don't know if it's how much I'm willing to take. Yeah, I think it's how much I'm willing to take, and when we're going to be doing that. And then another, part of the website that says, I'm an organization that needs, I'm looking to get vaccinated, and I have this number of phase 1B people. Right now, it's just open to phase 1A, but it might be the same process when we flip over to phase 1B. So those kind of things are going to happen as far as how do you fit the, especially when we go to phase 1B, how do you fit the people who have the vaccine to the people who need to be vaccinated? And I think that it's going to be local healthcare organizations and pharmacies in various combinations as being the vaccinators. And then a lot of different groups who are going to need to be tied together. I don't know on the Dane County level, you're involved with Dane County. Are they planning on doing that kind of matching like they are in Milwaukee County?
It's challenging. It looks like Sandy has some contribution. I'm just going to mention one thing very quickly, though. And one of the challenges is that we're seeing things being done above CDC levels to change CDC recommendations that preempt what ACIP has put out, which we're dependent on the state level to try and make a rational and doable rollout of vaccine. And so the latest we've heard is everybody over the age of 65 can get vaccine now, and there just isn't supply. And so take it away, Sandy, fix these problems for us.
Well, I can't fix the supply problem, but I'll tell you right now, like Paul talked about, if we have some openings, we'll take those public health people into our system and vaccinate them. So we're already doing that. Two, we're looking at different sites to do the vaccination at, probably at Big West and at Wingra. John Wall doesn't get them through fast enough. That's part of the problem. The other thing is finding space and people to get this done. And again, the supply, how much of the supply are we going to get? Right now, UW is only getting the Pfizer. We're going to need it for some of our outlying clinics, Belleville or Portage or Beaver Dam. We're going to need the different vaccines so we can do it. So lots and lots of work going on. The other thing is we are going to be outreaching through MyChart, but also we know not everybody has MyChart. We also can't do all of those 60 different order over, or we'll crash. MyChart will crash. system will crash everything. We learned that. I mean, Michelle Brogenet said she would help. And actually, we did talk about yesterday, will we need physicians to come in and help for 4 hours after hours to work with the vaccine if we have enough? I think that's going to be the limiting factor is, do we have enough? And then do we have enough people in order to do it? So lots and lots of work going on. People are, spending 68 hours a week working on this alone.
Yeah, and when you start looking at expansion, going from 1A, which was a pretty feasible target to hit, to 1B, Wisconsin really prioritized people that we thought would be easy to identify. So anybody, if you have an age cutoff, that's really, really easy to do. And you just have to be careful how big of a slice of the pie you make. Educators, K through 12 teachers are easy to identify. Fire, police are easy to identify. And I'll dare say mink husbandry people are pretty easy to identify. But once you get beyond that, it gets really, really, really difficult. So I can't really identify anybody on some of the definitions that Paul said that, well, I spend a chunk of my time within 6 feet of somebody else. We don't have that information anywhere in any record. And then when we start looking at things like people with underlying medical conditions, that's great if you're affiliated with a health system. And it's terrible if you're not affiliated. And so those are all those feasibility and ethical nuances that really get difficult when we're trying to figure out how to do this. At the same time, I think health systems can start enumerating, how many people do we have age 65 to 70? How many people do we have 70 and older? How many people do we have with these underlying health conditions? And start being prepared to do that.
Well, and UW Health has 32,065 and older. Somebody said if we were to immunize all at the rate we're going, it could take up to a year. So you got to start doing the numbers.
Thank you, Sandy.
Right. All right. There were a few questions covered already by Dr. Temte in terms of the prison population, but there was a related question about other people in more congregate living situations, and one specifically about where do residents of low-income high-rise housing fit into this? Any other types of crowded living arrangements? Will they receive vaccines sooner than the general population?
In our guidance, we put in transitional housing. That it gets difficult knowing quite where to draw the line. And in fact, I'm a big believer in having very fuzzy lines because, as everyone has said, that at the end of the day, when you have vaccine left over, you don't want to be in a situation where you discard it. I was quoted appropriately in the paper, though I've heard some negative about this too, but said the process we're using at the SDMAC, are far less than perfect. But at the end of the day, what's important is to get as much vaccine into as many people who are willing to accept it as fast as possible. And I'll stick by that because we just don't know the circumstances of anyone. And you look at a young person who is mobile with no health concerns, that person can transmit. And if we vaccinate, that stops that. So there are all sorts of nuances, but I think the takeaway is not to get too tied up in any of the specifics, but get vaccine out there to whoever is willing. And for the people who are unwilling, to work on them and try and make them more accepting. Right.
Well, we're coming up last minute. I'm going to give a 3-part question to try to tie in as much as I can. So a couple of questions about other side effects from the vaccine, not so much the anaphylaxis or antibody-mediated, but just incidence of side effects, safety for children and pregnant women, and there's a third part to that, but I'll give you the two parts first. So,
Well, pregnancy is not a contraindication. There have been a number of people in trials that have been found to be pregnant. We have not seen any ill effects at all. So far, so good with that. The studies are just underway right now with children, so I can't really comment on that because there hasn't been much data released. Paul, I'm not sure if you've heard more.
Yeah, so Pfizer went down to 16 and Moderna went down to 18. I think Pfizer is actively going down to 12 right now in their follow-up study. Yeah, so that's all. That's the only thing I have to add to that.
And on top of that, there really hasn't been any surprising safety signals coming out as of yet from the vaccine adverse event reporting system. So we just haven't heard of anything now in 3 million people.
Right. The other question, the third part was about transmissibility of COVID after you're vaccinated. Your ability to transmit.
So if you get infected, you can transmit. If you're 95% efficacious vaccine, then that's really what its effectiveness is in the real world. Then you have 1 out of 20 chance of transmitting. Now, the other question is, where the studies were only done with symptomatic, looking at symptomatic cases, but I think you could probably extrapolate that the efficacy preventing asymptomatic cases probably is similar, and we'll get more information about that when later on when they finish up the antibody testing that they have as part of the protocol to look for asymptomatic cases. But my guess is it's probably going to be similar. But yeah, I mean, you got a 1 out of 20 chance of transmitting because you could get infected. How do you look at that? I get that question all the time, John, and it's so interesting the way people phrase it that because I'm coming from a totally different frame of reference than people.
Yeah, I think you have to understand that the trials were designed to identify people who were symptomatic and to assess those individuals whether or not they were SARS-CoV-2 positive by PCR. None of the trials were set up to sequentially test people for viral carriage after vaccine. And in the Moderna trial, there was a little bit of that done after the first dose that showed a pretty nice reduction in carriage of virus in asymptomatic, but not enough for anyone to really stick their hat on. But from a theoretical standpoint, it makes really good sense that these vaccines will not only prevent disease, but prevent infection and carriage. But again, I'm hesitant to say once you're vaccinated, you don't have to mask anymore, you don't have to distance anymore. And so I think the wrong message is to say that we know anything about this when in fact we don't.
Well, you definitely have to keep masking, and you definitely have to keep social distancing because you may be that 1 out of 20 person, and you might not know because you have a 30% chance if you're with that 1 out of person, 1 out of 20 person that you're not going to have any symptoms ever. So, yeah, I mean, but I think that what I'm afraid is going to happen is that a lot of healthcare personnel are going to stop wearing their masks, especially at their workstations and when they're eating, and that you're going to get some transmission amongst those 1 out of 20 people to each other on site. So we got to keep masking, we got to keep social distancing and keep up, until the pandemic itself is over. So.
All right. Well, we are just at the edge of time. I think there's also a couple of questions about are things going to change at January 20th for coordination and supply? If someone wants to comment on that, and then I just wanted to highlight that Dr. Edgar's put in also a link on the online anti-vaccine movement in the age of COVID-19. So things that another obstacle to the rollout.
Well, I think the last comment I'll make is if we go back 12 months, very few of us had heard anything about the novel coronavirus. And for everybody who is angsting out there about vaccine not being available, I'll just remind them that in summertime, we were anticipating not seeing any vaccine until March or April, or maybe even later. And we didn't have any assurance that it was going to be over 50 or 60% effective. So keep in mind that there has been tremendous gain. We've, hit 30% of healthcare personnel in Wisconsin. Across the nation, there have been 3 million doses provided for a disease we didn't know about a year ago. And this is extraordinarily rapid. And it's been done with a high level of cooperation and has been done with a high level of safety. And so keep that in mind when we're sitting back going, well, why isn't this going faster? And it's like, I'm sorry, but you need to get real here. It's going along incredibly well, and we're very, very hopeful.
I just have to second all of that. I mean, when back in July, I was thinking, oh, let's at least please give us a vaccine that's at least 50% effective. And then when they came out as 95%, I said, that can't be real. I was like, I didn't say anything to anybody for a week or two about that study because I was like, that's not right. It's just too good. And then, the other thing is, when I heard Warp Speed would have, 20 million doses by the end of December, I was like, oh, that's good. They've been fairly on track with what they've been doing. And I think they probably can get, at least a quarter of that out. And so things are going at least as well as I expected them to go. So I agree with you 100% there, John.
Thanks.
Oh, wonderful. Well, again, thank you so much. And thank you both for your service on these committees and the important work that you did. We will probably be asking you back, I'm sure, in the next few months to give another update. Our next forum right now is scheduled for February 10th, and Dr. Brian Arendt will be leading a panel on food insecurity. So hope you guys all have a good afternoon, and thanks again. Bye-bye.